চলো।
ওয়েস্ট বেঙ্গল ডক্টরস ফোরামের পক্ষ থেকে আজকের যে আলোচনা সভা, সেই আলোচনা সভাতে আপনাদেরকে স্বাগত জানাচ্ছি। গত শনিবার থেকে আমরা একটা উদ্যোগ নিয়েছি, একাডেমিক ডিসকাশনের একটা উদ্যোগ নিয়েছি। আগে শনিবার আমাদের আলোচ্য বিষয় ছিল ইন সার্চ অফ রেশনালিটি ইন ম্যানেজমেন্ট অফ কোভিড-19। সেদিনের যে আলোচনা, সেদিনের আলোচনায় অল্প সময়ের জন্য এসেছিলেন প্রফেসর অরুণালক চক্রবর্তী। আজকের আমাদের যে আলোচনাটা প্রফেসর অরুণালক চক্রবর্তীকে নিয়ে। অরুণালক চক্রবর্তীকে চিনি আমরা অনেকেই। উনি হচ্ছেন পৃথিবী বিখ্যাত মাইকোলজিস্ট। বলা হয় যে তিনি পৃথিবীর 1 নম্বর মাইকোলজিস্ট। আমাদের পক্ষে একটা গৌরবের বিষয় যে উনি কলকাতারই এবং কলকাতা মেডিকেল কলেজ থেকে তিনি তার এমবিবিএস করেছিলেন। এবং আমার তার সঙ্গে আমার ব্যক্তিগত ভালো লাগার জায়গাটা এটা যে আমি যখন প্রথমবার স্টুডেন্টস ইউনিয়নের ক্লাস রিপ্রেজেন্টেটিভ হয়েছিলাম, সেবারে স্টুডেন্টস ইউনিয়নের প্রেসিডেন্ট ছিলেন অরুণালক দা। তো অরুণালক দা ইন্টারন্যাশনাল সোসাইটি অফ হিউম্যান অ্যান্ড অ্যানিম্যাল মাইকোলজি প্রেসিডেন্ট এবং বর্তমানে পিজিআই চণ্ডীগড়ের মাইকোলজি বিভাগের হেড অফ দ্য ডিপার্টমেন্ট। আজকের আলোচনা সভায় মডারেটরের ভূমিকা পালন করবেন ডক্টর অর্জুন দাশগুপ্ত। অর্জুন দাশগুপ্তকে চেনেন আপনারা। অর্জুন দাশগুপ্ত কলকাতার একজন প্রখ্যাত ইএনটি বিশেষজ্ঞ এবং ওয়েস্ট বেঙ্গল ডক্টরস ফোরামের ইমিডিয়েট পাস্ট প্রেসিডেন্ট হচ্ছেন অর্জুন। অর্জুনকে আমি ছেড়ে দিচ্ছি এই আলোচনা পরিচালনার ভার। নমস্কার।
Right. We will switch on between Bengali and English. If somebody has a problem, please drop in the chat box that you are having problem understanding Bengali. Then we will shift back to English. Thank you, Purnoda. যেভাবে তুমি এক্সপ্লেন করলে, যেভাবে ইন্ট্রোডিউস করলে, অরুণালকদাকে এক্সপ্লেনেশন কিছু লাগে না। There are diseases which we never heard of is coming back to haunt us. And COVID is one of them. It's a novel coronavirus, so it's a completely new entity. And as a year passed by, we have learned a lot. I think there is lot more to learn about it. And along with COVID, we are seeing some of our old horrors revisiting us. Some of the very rare infections that are known as a very rare infection. And one of them is mucormycosis, or as commonly termed by the media as black fungus. I won't take up your time anymore. So I will leave the floor to Dr. Orunal Chakraborty, and at the end of his talk, we will have some question and answer session. So try to just type in your question from now and try to stay relevant because we have already covered this before. So try to stay relevant and interesting. If there is a lot of, we pick up the interesting ones. If there is not much question, we will try to cover the whole of the question. Over to you, Orunalda.
Thank you, both Dr. Purnavata Gun and Dr. Arjun, for giving me this opportunity for discuss with you. I hope I'll go very slow because there are several issues where people have a lot of confusion. And in this area, I will try to explain it in the way a ordinary MBBS student can also understand. Okay, my title of the talk, which I have put in this, is the mucormycosis storm now in Indian sky. Friends, the issue is quite disturbing. Our media is calling fungi with the color, black fungus, white fungus, yellow fungus, what next? And being in the international forum, I really face big challenge. We have made ourselves laughing stock in front of the international scientific community by calling this name of the fungi with the color. First, I will say that mucormycosis is not the black, First, I will say that mucormycosis is not black fungal disease because you see this is mucorales. Here there is no black color. This is the black color which we see that is called Demetricious fungi. Some of the Demetricious fungi of course produce human infection, but the management of this group is completely different from the mucormycosis. So a doctor, when handling a patient, should know what he is trying to handle. So here in Demetricious fungi, there is presence of melanin on its surface, which is absent here. Now, if I say mucormycosis, like this is a very common species which we are seeing, Rhizopus aereus. Yes, there is some black color you can see. Then besides, I am showing you Aspergillus niger, which is equally black in color. And the Aspergillus niger also produce human infection. But the management again is different. So please, I would request all the scientific community to call this as a proper name. Yes, this term is very much there. Can you see that every paper, every day is highlighting this issue of mucormycosis? It's just like a deluge. Nobody could imagine that mucormycosis, which is called very rare disease in the Western world, has already in this month itself, more than 15,000 cases have been reported in government portal. And in our institute, already we have 144 cases in this month. Generally, mucorales are common in case of the India, or mucormycosis is common in India, and our institute is to report the highest number because of the awareness, reference laboratory, and many other issues. But even then, we used to report around 50 cases in a year, 50 to 60 cases, and you can see that only in this month there are 144 cases. Now, mucormycosis is the first fungal disease which has been made notifiable. Now, take a brief background about mucorales. I would say mucorales is ubiquitous in the environment. Even if you go to Antarctica where it had been isolated, or even in hot geothermal soil where mucorales have been isolated. And 27 to 30 species under mucorales are known to cause human infection. Out of this, Rhizopus, Rhizomucor, Lichthymia are common, but several rare species are there. I am not naming, but these rare species are quite prevalent in case of India. Now, in our environment, these are the two studies which we have conducted. In the environment of not only in PGI, we conducted this study in multiple hospitals. What we found in outdoor samples as well as in the hospital itself, both in air-conditioned wards and non-air-conditioned wards, or I would say ICU and non-ICU area, the spore counts is very high. And the common species is the Rhizopus aereus, which is the common agent. Now, mucor is so much prevalent in the environment, but we don't get mucormycosis. The reason is, until unless your immunity is compromised, there is no chance of getting mucormycosis. In case of this, there are certain area or anatomical site on the basis of that, we call different names with the mucormycosis. Like when it affects the nose, eye, or brain, we call it rhinocerebral variety. When it affects the lungs, it calls pulmonary variety. When it affects the gastrointestinal tract, it is called gastrointestinal mucormycosis. When it affects the skin, it is called cutaneous mucormycosis. And when it's spread across the body, that is called disseminated variety. With each one, there are certain risk groups which can be or which have been found to be associated. Like disseminated seen in immunocompromised host, rhino-orvitocerebral had been found in uncontrolled diabetes, which is one of the major issues which I'm going to discuss with you. Pulmonary, it's seen in hematologic malignancy, who is undergoing chemotherapy, or transplant patient which is under immunotherapy, they are having. Some of gastrointestinal mucormycosis in India is quite not so uncommon, and it had been seen in case of premature babies and malnutrition. Cutaneous variety happens especially after roadside accident when your wound gets contaminated with the soil, and if you cannot clean it properly, there can be cutaneous mucormycosis. Of course, in India, we have seen cutaneous mucormycosis also In case of the villages or in case of the area where contaminated injection has been or injection syringe has been used to inject any of the drug, and there is development of mucormycosis. So here, with this background, if you see in our COVID-19 patients where we are going to discuss COVID-associated mucormycosis, majority cases are rhino-orbitocerebral. Few cases we have observed a pulmonary and very occasionally in disseminated. Now the problem with India is that there is very high incidence of uncontrolled diabetics. We love sweets. We are very scared to do our blood sugar level. If I am hypertensive, though I have to take throughout my life antihypertensive, I don't care so much, but I care to do blood glucose level. The reason is, of course, we love sweets, we don't want to avoid sweets. So compliance to the anti-diabetic therapy in India is very poor. We have studied this and found that 23% patients in our study were ignorant of underlying diabetes. They came first with mucormycosis, but then when it had been studied, they found very high level of blood sugar. So we did a study, quite old study. It was in 2004, consecutive diabetic patient, around 22,000 diabetic patients, we found 35 cases. So you can see the incidence is quite high in this population. So in that situation, mucormycosis is different in India compared to the rest part of the world. This is our data which we have published, and we have shown that in general, India prevalence in case of mucormycosis is 70 times higher than the incidence in the Western world. Here, of course, we have those cases like hematologic malignancy, transplant patient, but somehow uncontrolled diabetes overshadows all other risk factors. So we see more commonly rhinocerebral mucormycosis. Of course, as I've said, in India, we also see high number of gastrointestinal mucormycosis. But this particular entity is very peculiar for India. Young person suddenly had fever, flank pain, hematuria or anuria, and when you do some imaging, you see there is infarcted kidney. Why this immunocompetent patient develop mucormycosis is very difficult to say. We are studying for long years, but yet we don't have the answer. Possibly there is some issue of genetic susceptibility in this group exists. Now the spectrum already I mentioned is quite wide, of which Rhizopus aereus is common, and the rare agent somehow is quite common in India rather than in any other countries. Now coming to this COVID-associated mucormycosis issue. You know, last year we had just seen occasional case report across the globe, and suddenly there was the 18 cases reported from Bengaluru from 3 eye centers. In one city it had been reported. So we collected the data across the whole world about this COVID-associated mucormycosis. We found nearly 2/3 of our cases from India, and uncontrolled diabetes and systemic steroids were the major predisposing factor, and rhino-orbitocerebral mucormycosis is the most common presentation. And you know, rhino-orbitocerebral mucormycosis, our management is much easier because we can diagnose early. We can get the sample. Dr. Arjun can collect a sample, sent to the microbiology lab, and within half an hour to 1 hour, the report should come, there is presence of mucormycosis. But here you can see mortality is much high because the patients are reported late. That's very important here for this discussion today. Very recently, this review had been published again from the world, where 87% cases had been shown from India. Males were more common sufferer, and it had shown that active COVID, during the COVID period, around 60% have the infection and 40% post-COVID. Pre-existing diabetes, 80%, diabetic ketoacidosis in 15%, corticosteroid intake was very high. I involved in quite number of patients, but in that study, somehow mortality had shown around 31%. Whatever it is, even then, the mortality is very high. So last year, we conducted this particular study. This is just accepted in this week in Emerging Infectious Disease, going to appear quickly in the next week. I can share this paper. That paper is very evidence-based, showed first time what are the major issues in case of COVID-associated mucormycosis. Last year, we have found that compared to 2019, there was a rise in over twofold in case of mucormycosis. What we also found is that it is more common in older patients, and peculiarly more males, they suffer from this infection. And when we looked into the total COVID patient, we found the prevalence is 0.27%, and those who are treated in ICU, 1.6%. Apparently, the percentage looks to be very small, but if you look into the total number of COVID patients in India, the number of COVID-associated mucormycosis would be significant in number, even last year. 86% of them have this nasoorbital or rhinoorbital mucormycosis, but you see 1/4 of them already brain involved. And around 8 to 9% there is pulmonary mucormycosis, 2.1% disseminated. And you see diabetes was a very important factor in 62%, and steroid had been given in 71%. It's very interesting. You see, diabetes we are pinpointing, but COVID alone was underlying disease in 1/3 of this patient. And these patients received steroid. So these are the non-diabetic, because of steroid, possibly their blood sugar had gone up. Most important, this is another finding, or I would say this is really helping us when to advise and what to do. Majority of the COVID-associated mucormycosis were diagnosed more than 8 days, and median is 18 days after COVID diagnosis. So you see this waterfall figure where it shows that the median comes on 18 days. That means by that time patients are already discharged. So you have to advise the patient about the early symptoms and signs so that they can report early to you. But this is the important. Of course, hypoxia had been found to be significant in multivariate analysis, but I would say that inappropriate steroid therapy was 63.3%, very significant. But there was no media report then. But what happened now? The question comes, why this surge happened with this second pandemic? I generally put it in these 4 points, though these are not very clearly yet evidence-based, but indirect or last year data, if we interpolate this, these 4 factors come into it. One is the diabetic factor, steroid factor, COVID factor, and environment factor. Of course, diabetes has been seen around 30% patient of the COVID patient, and already I've mentioned uncontrolled diabetes is common. But this is the very important issue happened in this second wave. When there was no bed, when there was oxygen was crisis, what the doctors were doing, they could not do the glycemic control of these patients. They were not, I would say that, they were not able to do the glycemic control. And when they are not getting oxygen in oxygen desaturated patient, they went on increasing the steroid. WHO said you must not use more than 6 milligram dexa per day in case of any patient. But in some of the patients, they have used even up to 30 milligram dexa per day. 5 times they have used. So their sugar has gone through roof. Now coming to this COVID causing problem, which I am going to analyze a bit more, and how environment played important role. Now already I mentioned diabetes is important, and many patients who have not tested for diabetes, that might be also important factor. But now coming to COVID-19, what they can affect. First thing is that they indirectly had enough evidence now that COVID-19 virus may affect beta cell pancreas, damaging it, resulting in metabolic derailment. Also, as it affects the blood vessels, smaller blood vessel, the circulation to pancreas also going down, that also affects in this scenario. Next, of course, steroid, which I have mentioned, that is the major issue today. Also, steroid impaired the neutrophil migration, ingestion, and even the macrophage function. Next, in case of this COVID, the stress-related hormones especially in case of severe COVID, it happens. And that releases cortisol and adrenaline, which further raises the hyperglycemia. So one thing is very clear, hyperglycemia is taking important role. Now, because of this hyperglycemia, there is an inflammatory state. And in case of this antiviral immunity in COVID-19, that also potentiates the inflammation. So because of the inflammation, what it happens, first thing is that there is alteration in iron metabolism. In severe COVID-19, IL-6 stimulates ferritin synthesis and downregulates iron export. So there is development of a hyperferritinemic syndrome. Excess intracellular iron inside the cell, which raises the reactive oxygen species, resulting in damage of the cell. So free iron comes in the circulation. And possibly you know, iron is a good food for mucorales. They have on their surface receptor which is called siderophore. Through this siderophore receptor, they absorb the iron and that helps in growth or flourishing these mucorales. Next important thing, COVID-19 issue causing the endothelitis. Whatever the autopsies has been now done in case of the COVID-19, especially there are 2 series published, it showed that there are severe vascular endothelial injury. And this vascular endothelial injury is much higher than in number of influenza and post-H1N1. So this endotheliitis helps in entering of these mucorales inside the circulation. I will try to explain with a cartoon. See, this is the endothelial cell, and what it happens, high glucose, free iron, siderophore, all these plus diabetic ketoacidosis cause the endoplasmic reticulum stress. With this endoplasmic reticulum stress, this GRP78 receptor is overexpressed. It is coming out. And here, mucorales have this COT-H3 receptor. So it can adhere very quickly to the endothelium. And that causing damage to this endothelial cell. And finally, it helps in penetration of this endothelial cell. And there is what we see, thrombus formation whenever it is going inside. Finally, there is the ischemia and hypoxia. But one factor we are not very sure, which we are studying now. You know, in COVID-19, immune dysregulation is there. There is T cell and B cell problem is there. There is this factor, how much is anti-mucor specific factor, which we are presently studying. So there is these particular things I cannot answer, but I say that possibly immune dysregulation also playing the role. So this is the cartoon which have been just published again. One of this Indian person had done it. You can see the same thing which I have said, corticosteroid, diabetes, COVID-19, there is IL-6 increase, ferritin increase, all these factors together finally causing mucormycosis. And for a layman, if I have to explain in this way, yes, both indoor and outdoor air, we have enough amount of spore, we are exposed to it. Now, there is a COVID infection. Because of this COVID, we have given dexamethasone if it is more than 6 milligram and the patient is diabetic, there is already development of ferritin and endothelitis. All these things together ultimately developing this COVID-associated mucormycosis. Now coming how to diagnose. It's very easy in case of rhinoorbital cerebral. You need a surgeon like Dr. Arjun who can collect the sample by endoscopic collection and send to the lab. Immediately it can be diagnosed by just putting a KOH mount. Radioimaging helps to know the extent of the disease. But the problem in case of pulmonary mucormycosis is not so easy. You have to differentiate with another disease which we have highlighted, that is COVID-associated pulmonary aspergillosis. You see that in pulmonary mucormycosis, the symptoms and signs are very non-specific. It overlaps with the COVID-19, and when you say that you have to collect BL sample, bronchoalveolar lavage sample, transbronchial biopsy, CT-guided lung biopsy, or care required for the COVID-19 patient is very difficult to collect. Imaging, we know these are the characteristic imaging in Mucor, reverse halocine, thick wall cavity, multiple nodule pleural effusion. But again, this reverse halo sign had also been seen in COVID-19 patients with immunosuppression. And cavitary lung disease can also be seen in case of COVID-associated pulmonary aspergillosis. The management is different. So what I suggest, I don't know whether this test would be available in case of West Bengal or not. At least Tata Medical Center is doing some of the tests. What we know that repeated negative galactomannan beta-D-glucan has excludes COVID-associated pulmonary aspergillosis and diagnosed COVID-associated pulmonary mucormycosis. Now, this is also very interesting. What we are now seeing that in 5% of the cases, not only mucor, it is a mixture of infection. You can see this broad hyphae of mucor. Along with this, there are also these thin hyphae. These are in case of the aspergillus. So this is a mixture of infection. So possibly you have to treat both mucorales and aspergillus together. Now, as I said, that the most important thing is that you have to come early. So as the patients are getting this infection around 18 days when they are going home, you have to advise them what are the early symptoms and signs. Possibly Dr. Arjun can say it much better, but here what we see is that nasal blockade, congestion, nasal discharge, facial pain, numbness, swelling, fever, headache, orbital pain. I don't think you should wait that period of time. You should report early. But this is very interesting. This time, in this group of COVID-associated mucormycosis, number of centers have reported that jaw getting involved, and because of the jaw involvement, there is loosening of the teeth which have been there. But as I have said, pulmonary mucormycosis, nothing you can really say until unless there is a good clinician along with laboratory help is there, you cannot diagnose pulmonary mucormycosis. Now, we all know what is the management of mucormycosis, though I am going to say very saliently. But one important thing happened is that absence of the amphotericin B drug. Because of this unprecedented surge, there was the real problem happened in case of amphotericin B availability. So what I did is that we ran a body called Fungal Infection Study Forum, from which I approached the European and USA experts and tried to explain the situation and got their approval also for supporting this particular guideline, which we have issued as a Fungal Infection Study Forum guideline. First thing, of course, we have to do the diabetes controls, reduce steroid, discontinue immunomodulator. We need to do the extensive surgical debridement. If the eye is involved, don't mercy, please do the exenteration. In lung, if it is localized, you can do the lobectomy if it is one lobe involved. But the issue here is about the medical therapy. Now, in the medical therapy, if you can have this liposomal amphotericin B, good. You know the dose, I am not going into the detail of it. If lipid amphotericin B is not available, try with the amphotericin B deoxycholate. Though it is a bit toxic, but I know Indian clinicians are quite expert in using amphotericin B deoxycholate. But again, this drug is also not available. So when polyene is not available, when the patient is intolerant to polyene, go for doing either isavuconazole or posaconazole. Even when posaconazole or isavuconazole is not available, this particular drug never recommended in case of mucormycosis, but we have enough data on in vitro susceptibility and also few cases which have been seen with itraconazole management, which really made us dare to think about this particular drug. I again repeatedly say, this is not the drug of choice. When you don't have any drug, don't leave the patient. You can try itraconazole. In many states now, people are using itraconazole when they are not getting the polyene drugs. Of course, mucormycosis management is a very long management. After 3 to 6 weeks therapy or primary therapy, then you have to go for the consolidation phase where you have to go for 3 to 6 months. You can easily see any of the literature shows what are the drugs to be used here. But friends, there is some misinformation and misleading information which I like to highlight. First thing is that mucorales are not black fungi. Second important thing, mucormycosis is not contiguous. A lot of people are scared about it. We don't have any patient besides the mucormycosis, this useless proposition. There is no mucormycosis go from one person to another. This is very important. A lot of people enthusiastically started using in diabetic patient antifungal prophylaxis, but it is not recommended. Please don't waste the drug. Please don't increase the expense or cost or treatment of the patient. You know, whenever we say any antifungal prophylaxis, we look into the cohort, whether it has got enough percentage of infection so that if you treat one patient, how many patients are going to get this drug unnecessarily? So the thumb rule is that the incidence should be in a cohort more than 10%. Till now, we don't have, though we have got a storm of mucormycosis, still I would say in COVID patient, it had not gone beyond 10%. Avoid dose escalation. Old school of medicine said amputation be used, slowly escalate the dose. This has now abolished. On the very first day, you calculate the dose, give the full dose. These are the drugs are not effective against mucorales. Voriconazole, fluconazole, echinocandin, 5-fluorocytosine. A lot of patients are on these drugs. I would request you, please don't use combination of the therapy, antifungal therapy. It's generally not recommended, as there is little evidence in support of it. A lot of people ask me, from these onions, from these black molds inside the refrigerator, is it mucormycosis? Friends, these are not mucormycosis. These are the grapes where you can see this mucor growing. So please, all black are not mucor, and mucormycosis is not black fungi. That should be very clear. Those who are research-minded, I would say that these are the questions which I am pursuing. I need help from all of you. First thing, as I've said, COVID-19 causes immune dysregulation. Is there any mucor-specific immunity disturbance? High incidence in the second wave is unprecedented. So we are looking into this. Can these new variants cause more mucor-specific immunity disturbance? Is there any genetic susceptibility issue in Indian population? Though we see rhizopas is more common, we are now doing a study. We are comparing the rhizopas isolated presently with the rhizopas in our store from the earlier years isolate. Is there any acquired virulence in rhizopas aerogenes? We are also trying to look into this environmental correlation with the patient isolate. Many more research questions are there. This is a very important time, those who are research-minded, to look into to answer this question. Lastly, I would say that how to prevent this COVID-associated mucormycosis. As poorly controlled diabetes is the major issue, we need good glycemic control. Second important thing, oral steroids are contraindicated in patients with normal oxygen saturation. I don't know what happens, why you people are not really opposing this type of ideas of giving this so-called these antibiotics, azithromycin, doxycycline, ivermectin. Nobody has proven the efficacy of it. Even these patients are giving steroids unnecessarily when there is no oxygen saturation loss. We have got COVID-associated mucormycosis in such type of patients, though there is no oxygen desaturation. Systemic steroids should only be used when the patient is hypoxemic. And the dose should never be used more than 0.1 milligram, that means 6 milligram per day. And it should not exceed more than 5 to 10 days. Those who are diabetic, uncontrolled diabetic, had exposed to COVID, acquired the infection, cured of COVID, I request them, please use mask even at home. The reason is, in your home environment also, mucorales are very much there. So it would reduce your exposure to mucor. This ordinary, this linen mask is enough because mucorale spores are very big. It is 3 to 11 micron. Surgical mask or linen mask is enough to have in this situation. avoid construction site when, especially 1 month to 2 months after getting over this COVID. I'm saying this is specifically those who have uncontrolled diabetes. During discharge of the patient, request the doctors to explain to the patient, come with early symptoms and signs when you have mucormycosis. So friends, summarizing, I took 5 minutes extra to go slowly. COVID-associated mucormycosis should be suspected in diabetic patients with severe COVID. People ask me, tocilizumab is important risk factor. I found this study that tocilizumab has a negative impact on hyperglycemia, so we may not be able to pinpoint that tocilizumab causes mucormycosis. Yes, tocilizumab increases the chance of aspergillosis, but not so much in mucormycosis. Steroids not given indiscriminately. Good glycemic control is desirable. Suspect the disease early. Patient need to be advised with early symptoms and signs. In our multivariate analysis, we found that these are the group of patients who have got high mortality, older age diabetic ICU admission and glucocorticoid therapy, so we need to be cautious. But again, I would say that we need some research for a biomarker test in case of mucormycosis. Early diagnosis, prompt therapy are essential to minimize the mortality. But friends, this is another important issue in case of mucormycosis. In 2019, we conducted a big study in India, again that multi-center study, to know how the clinician treat mucormycosis. We are surprised that a lot of people give fluconazole, but most disturbing fact is 25% patient left the hospital or could not complete the course of the therapy because of cost constraint. So this is a very important issue, and I think Dr. Punnabroto would take this issue very seriously, so that, because in a common man or a poor man, if developing this mucormycosis, then it's real challenging how he can afford the therapy for almost 6 months. Thank you very much for your kind attention.
Thank you. We are going to the question and answer. First question, Onlokta, is, just let me get the question. Sorry, just give me a minute. Somebody is asking whether there is any, is having a rhino-orbitocerebral mucormycosis with cranial involvement. Is there any role of surgery in that? Douching with liposomal amphotericin B, sinus surgery, and treating with liposomal amphotericin B as well.
See, the question here is, if there is cerebral involvement, whether you go for the neurosurgery or not, or you can overcome the issue only with the drug. That is the exact point possibly is trying to go through it. Today morning, I got a phone call from Calcutta. I don't want to name the hospital. The same problem was there. One of the patients who is having the infection has spread to the frontal and temporal lobe. And it was, the question is whether what to do, because patient is doing okay, but already one eye exenteration, other eye, there is chance of getting involvement. Is there some vasculitis is there? So what should be done? First thing is that with this vasculitis, I request you, please don't use steroid. People have a general impression is that in any vasculitis, you should give the steroid. But here it has shown that it rather increases, creating problem. Second important thing is that if you can remove the all necrotic material, even from the brain, that is desirable. The reason is mucorals, whenever they enter the blood vessel, they cause infarction, causing tissue necrosis, and it remains inside, where the drugs is very difficult to reach inside. So here, if you can take out, that is the most important. But I would say that in case of the drugs, both amphotericin B and isavuconazole has good barrier, they can cross blood-brain barrier. It can go inside the CNS. Posaconazole is still not very clear, but because there is no bioavailability study in case of posaconazole in CNS infection. But I would say that if you cannot do the surgery, then drug is the only option. So if I ask straight away that drug would help or not, I cannot say. Some of the patients it helped, some of the patients it could not. So surgery is the major issue.
Second question is, why was there no surge of mucormycosis during the first wave in India? I think you answered that. Let's just touch on this.
We had a 16-center study during that time because our antenna is much sensitive. Whenever we see little higher number, we immediately plan study, and we conducted the 16-center study. But again, you know, anything has to first highlighted by US media, then Indian media, they get up. Like we had another fungal disease, which is called Candida auris, which is a very disturbing because that is multi-drug resistant, which was first being isolated again from Calcutta during our study in 2009. And this particular infection is very high in India. We highlighted several times, but never got the media attention. It was only when it reached in 2017 USA, then all the media suddenly come to me, what is this Candida auris? Can you tell me? Can you tell me? I said, when we have highlighted during that time, nobody bothered. Same thing in case of mucormycosis. If people or media would have highlighted this issue in last year, possibly this situation would not happen like this, possibly.
Another is the mucor resides in the submucosa, not in the mucosa. So what is the probability of isolating mucor with a nasal swab?
Generally, mucor is never a commensal organism. Whenever you isolate mucor from the nasal sample, you have to give importance. Aspergillus is of course a commensal sometimes, but in case of mucor, we don't see such commensalism so much, but probability or possibility is there, you can see it. I would rather suggest that best sample would be taking the necrotic material by doing nasal endoscope, I presume. Arjun, you can explain, is it a difficult procedure?
Not at all, not at all. It's a 2-minute job for us.
It is a
and it is a simple procedure in a distant villages and Mofussil as well. Towns, the ENT surgeons do now have endoscope. So it is a very common practice to do nasal endoscope.
If you can collect the sample with a nasal endoscope, then you can diagnose it much more definitely. Otherwise, you may miss the, because Dr. Arjun can explain you better because he being an ENT surgeon. Usually it doesn't remain in the nose so much, it goes into the sinuses. And you cannot reach the sinuses by a nasal swab. You have to collect the sample. You may explain it better.
There are some early signs of mucor which you can pick up with a nasal endoscopy, the blackish char and things. So if your antenna goes up and you are seeing a mucor, then obviously you go for the MRI scans and you go for biopsies. And most of the time it is possible in the ENT clinic setup with a little bit of local anesthesia. If it is not, then arrange for a debridement as sending the biopsy at the same time. Because as Onalogda has already mentioned, it takes only half an hour for the KOH stain to confirm that it is a mucor. So while you are doing the surgery, you send the stain material to the microbiologist, obviously inform them before, and within half an hour, they will tell you whether there is a mucor or not. And then you can either improve the surgeries or tone it down according to what they have told you. The third question is, a dentist, kindly, can you give us some guidelines about dental surgeons working in hospital and private clinic setup?
That it is the, not question, it is a more a suggestion for the dentistry people. Yes, they need a awareness, and I have got multiple experience during this whole period. There was a email came from a Pune person. The lady complained that her father-in-law, who had got COVID, now he had loosening of the teeth, And because of this surgery had been done, somehow she could confirm that there is presence of the mucor in the biopsy tissue, which have been collected from the jaw surgery. And then he asked the dentist, he said, you take antibiotic and that is okay because I have completed the surgery, nothing to be done. So she asked me what I should do. I advise that you go to an infectious disease clinician with this report and try to get proper advice from there. So I feel that the awareness in the dentist is required. They should also try to learn how to manage or what are the issues are there. As even in case of ENT surgeon, Dr. Arjun is sitting here and he may not accept my friendly criticism, but you know that in case of the ENT surgeons, lot number of people, they feel that it is after good surgery, if you give 2 weeks therapy, that is enough. But I have seen so many cases of they come back with this recurrence. I'm not saying you, but there are several of the ENT surgeons have that belief. And in case of my national task force, I had to really struggle with them because of this particular perception. So I think the awareness is required in every form in case of mucor.
Shoma Chakraborty and Rumpa Shah is asking, is there a role of zinc in this mucormycosis epidemic? Yes.
Today itself, there is a reporter from Anand Bazar in the lunchtime asked me, what is the role of this zinc? I said that, look, there is no evidence yet that zinc really helps in case of mucor. There is a paper which have been studied the zinc chelator, which takes away zinc. This zinc chelator had been mixed with amphotericin B to look into synergistic effect in the in vitro study, means in case of laboratory. They found that zinc chelator really possibly help. Now, the opposite logic, if I have to put, that zinc has been recommended by WHO in case of COVID patient for since long. And zinc had been used throughout the world in many patients in COVID. But we have not seen mucormycosis. But in spite of all these things, always, you know, people are happy when you have got direct evidence. So at present, a study is going on at our center where we are collecting the samples from the COVID mucormycosis. We are looking to the zinc level and non-COVID patient without mucormycosis zinc level. And also we are trying to see in our media, if we add zinc, whether it increases or not. I would rather say that all these questions diverge the major attention, that is the blood sugar and the steroid issue. That is the major issue. These are the possibilities, you know, everything can contribute. Something or other can contribute. But until unless it is proven, we should not, yes, this can be, but there are against logic is there that zinc is possibly not so important.
Role of three things in mucor, increasing the of mucor in COVID patient: water in humidifier, steam inhalation, and wearing masks.
The same questions comes repeatedly. First thing is that in case I will add to it the oxygen and industrial oxygen use, because the same questions I have faced everywhere. First, let me say in case of industrial oxygen is 98% pure for oxygen. Medical oxygen is 88% pure. And in industrial oxygen, what we see is that because if we have got a very pure oxygen, none of the microorganisms, because oxygen is also very toxic, none of the microorganisms can grow. In spite of that, what we did is that because there is a Brazilian study which had shown that in the pipeline of the oxygen, there are few bacteria produce the biofilm, like Staph epidermidis is producing biofilm. So we have already studied in 3 centers the source of the oxygen pipeline, and at the outlet. We didn't find any mucor in any of these centers. Second thing is that in case of humidifier water, you have seen that in humidifier, the water, when the oxygen is passing through, that is producing bubbles. There is agitation in the water. Whenever there is agitation in the water, any mucorals cannot produce spores. For producing spores, they need a static environment where they can develop these spores. Now, spore is the main infecting agent. It is not the hyphae. So there is no possibility. In spite of that, we have also checked the humidifier water in those 3 centers. Only in one center from eastern part of India, I am saying it is in Bhubaneswar, the microbiologist found there is one colony of Demetricious fungus, not Mucur. It is one colony of Demetricious fungus. Otherwise, there is no Mucor which have been found in water. Next, coming to the mask. You see that in case of the mask, now we are studying it. We are studying the 100 dirty masks. We have gone, my friends, my colleagues have gone there carrying the new mask. And whenever you see any dirty mask, take out it, give it, and we are doing the scraping and trying to say whether mucor is there or not. Friends, mucor can be seen easily. If your bread is having mucor, you can see it. If your mask is having mucor, you can see it. What is your problem? Mucor can be seen easily macroscopically, means in your own eye. Do you use those when there is a fungus? Do you eat? Don't eat the bread when it is contaminated with fungus. So I'm saying you, these are the, yes, these propositions are there, but there is no evidence which could suggest or support this hypothesis.
Okay. Inhalation steroid role in mucor?
Yes, that is also a discussion happened amongst all our ID people. It's not very clear because inhalation steroid was not given to too many patients in COVID. So we are not very, at least in our study last year, we didn't find anybody with the inhalation steroid of so many patients we have studied. But that's another area which need to be looked into. I have no answer, clear-cut answer to it.
Okay. In a suspected cases with necrosis evident in MRI, is it necessary to take a biopsy and wait for the report to come or directly proceed for debridement?
I would rather suggest you that clinically, if you think it is mucormycosis, immediately start the drug. Immediately start the drug. That is very important because mucormycosis can change your life within 6 hours. Once it enters the blood vessel, it can grow very fast, it can spread very fast. So start with the antifungal, then look at the report. If it comes negative, stop the therapy. That's the usual way you should proceed.
Role of prophylactic intake of methylene blue?
Again, I would say that there is no evidence, but the thing is that this need to be looked into, but there is nothing which we could see. Again, I have missed one point. Sorry, that is about the inhalation of steam.
Yeah.
Inhalation of the steam. You know, whenever you take hot tea, if it is too hot, generally after first sip, you take it. Our whole, the oral mucosa, all the cells are very, very sensitive. And this sensitivity is so much, if your steam is intolerable, it would not allow. It will not allow that steam to cause damage to your mucosa. This proposition comes from that steam causing damage to the mucosa and mucor enters because of that. But usually steam never causes damage because your body protects. Until unless it is tolerable, body don't allow your face to be there. Until unless you are somewhere in the jail khana and somebody has been giving you punishment that you have to be burnt with this. Otherwise, there is nothing in that way.
Okay. Lots of questions coming in. We may not be able to cover all of them because Anuragda is a very busy person. We will send questions to him by email. So we will try to finish as much as possible. What is the sensitivity of KOH solution, mount preparation in detection of rhino-orbitocerebral or pulmonary?
Generally, if you can repeatedly, because If the clinician, you need a good rapport between the clinician and microbiologist. If the clinician is suspecting, you please prepare another smear and try to look it. And I would say that almost 100% sensitivity you can have if you have got good correlation, because if you have a good sample collected by the clinician and you are looking at it and you are a good microbiologist, you can easily pick it up. So I would say expertise is more important, and the rapport between the clinician and the microbiologist is important.
I will request Shankar, can you just copy paste all the questions and just keep them somewhere if we can't finish. Rate of growth on Mucor in vivo, Shushmita Bhattacharya.
It is very profusely it can grow. Nowadays, what is happened that these patients are so much prolific growth, prolific Mucor is there. Today itself, one of the histopathologists sent me a photograph that even the sporangium is there inside the tissue. I said it is not in the tissue, in the sinus there are a lot of air is there and Mucor is entering there, and whenever they are getting the chance of mixing with the air, it produces sporangium. And these Mucors, like suppose daily we are getting around, now from last 2 days the case numbers have come down, but we are seeing whatever the numbers of cases we do the culture, we find within a day mucosa growth is there. So it's not taking much time. It would, within 2-3 days you can have the growth.
Insulin resistance in obese patient and mucormycosis. Any increase in susceptibility to mucormycosis in such patient, Dr. Buddhadev?
See, the thing is that what we have done, we have daily put in the susceptibility. Mucor has got a very variable susceptibility with antifungal drugs. Like everybody says amphotericin B, like one of the fungus named Apophysomyces elegans, where the amphotericin B susceptibility is not good. Similarly, in case of there is Cunninghamella, there is also the susceptibility is not good. And Cunninghamella, that's why mortality is very high. And there is also strain variation. But there is no change in case of susceptibility pattern during this epidemic which is going on. It is the similar susceptibility pattern which you are observing.
Okay. Somebody is asking for your email address.
Yeah, Purnabhrata Goon has my email address.
We'll share it with you. Does the liberal use of antifungals during the tinea epidemic could be one of the reasons for mucormycosis? And this may be the last question.
Tinea epidemic is superficial tinea infection, and there is whenever you are given the therapy, that is terbinafine, that is systemic therapy which you have given. Terbinafine rather has got a variable susceptibility with Mucor. I would not say that could really selects out the Mucor. That's a remote possibility. But we have no evidence in supporting this particular proposition.
Any difference between liposomal amphotericin B and deoxychelate? Any difference in efficacy?
I would say that in case of efficacy, there is no difference between amphotericin B deoxychelate and liposomal amphotericin B. Friends, this should be very clearly, I always say very categorically. A lot of people discard it. Even in our global guideline, I had to struggle with my European colleagues and USA colleagues to put amphotericin B deoxychelate in the guideline. You know, they have a lot of money. They can easily discard amphotericin B deoxychelate, saying that it is very toxic drug. I can ask Dr. Arjun, he also definitely have used amphotericin B deoxychelate. Yes. We are not having the people who can afford. What is the cost of liposomal amphotericin B? Forget about the black market now.
15 lakhs.
Amphotericin B ambisome, it is 5,000 rupees 50 milligram. And if you go by the proper dose, it is 5 milligram per kg per day. So it is 350 milligram you have to give daily to a patient. 350 milligram means it is the 7 ampule. 7 ampule means 35,000 rupees daily. 35,000 rupees daily, how many people can spend and you have to go for the therapy at least for 3 weeks. So amputation.
We are counseling for 15 to 20 lakhs to the patients.
Yeah,
And you can understand, even for me, that will be difficult. I mean, forget about the common patients.
So I would say that amputation with deoxycholate, efficacy wise, yes, it has got toxicity. You have to be very careful. Before giving amputation with deoxycholate, put 500 liter of normal saline wash, and post you can do 500 ml normal saline wash. Even you can do a peri-wash during giving in one hand, normal saline, other hand, and you can go for 24 hours slow therapy, 8 hours slow therapy, 12 hours slow therapy. All these are the people by their experience have learned it. We have to treat the patient with amputation with deoxycholate.
Okay, last question, Orlanogda. Rumpa Shaha, she was your student. She's saying that the chances of giving, when we give a liposomal amphotericin B in 5% dextrose, this will also increase the blood glucose levels.
Yes, that is true. Because of that, a lot of people have raised this question. But you do the glycemic control, that is there. One bottle of 5% dextrose will not completely change the scenario. And this glycemic control cannot be done with the tablets. You have to do the insulin, which have to take control during this particular mucormycosis episode. You cannot rely on the tablet viability. You have to be with the insulin that is there.
Okay. Dr. Orlanogda, I will call you Orlanogda because Wbdf, it is fantastic. I mean, amazing. I mean, we are also seeing in this way, we are seeing Mucor every day. And it was so much enlightened. And I just cannot even think that on a Saturday evening, talking about fungus, there will be so much attendance and there will be so much interesting question. We have your email address. We will send you the rest of the question. So if you can just voice record or do something, we will type it out and send it to the individuals. So thank you very much. Thank you all on the behalf of Wbdf and for a very lovely evening. And probably we will need Orlanogda again, so we will bring him back soon. And please keep your eyes open for similar programs. We are delving into, and now we can see Wbdf is delving into academic programs and equally excellent programs coming into the future. Thank you, Orlanogda, again. Thank you for everybody. Thank you, Kaushik Chakki.
And really, this is, I enjoy always being a teacher. I generally enjoy discussing with them. I can go on answering 3 hours questions. And if I cannot answer, I have nothing to hesitate say that I don't know. I would like to go back and try to find the answer to this. So I have no hesitation saying that. I don't have all the answers. Thank you very much.
Okay, the last thing is for everybody in here, this program is recorded. And because Dr. Orlanogda has insisted on a medical audience only, so we haven't advertised it to the outside audience and to giving it to everybody. There is a chance of leaking and non-medicals coming into this program. So we tried to keep it tight, but there will be a YouTube link coming soon. And all Orlanogda has said about Mucor will be there. You guys can just see the recordings and all the questions will be answered over there. Thank you very much. Okay. Very good evening, very good night, and
thank you.
Thank you.